Good evening, everybody. My name is Dr. Onwuchekwa Ugochukwu from National Hospital. Today, we'll be discussing on the basic considerations in pediatric anesthesia. Our discussion will be under the following outline: an introduction, relevant anatomy, physiology of systems. We will talk about the pharmacological differences between inhaled anesthetic, intravenous, and muscle relaxants. We'll go to the pre-operative, intraoperative, and post-operative considerations. We'll have an overlook on the day case and conclude. As a way of introduction, I want to start by saying that children are not small adults. The pediatric anesthesia involves more than simply adjusting drug doses and equipment for smaller patients. Children of different age have differing anesthetic requirements. A safe anesthetic management depends on full appreciation of the physiologic, anatomic, and the pharmacological characteristics of this age group. Now, the pediatric age group could be divided into different groups. We have the preterm, which are children born less than 37 weeks of gestational age. We have the neonates 0 to 1 month. In some climes, we have the neonates are 0 to 2 months. Infants are 1 month to 12 months old children. Toddlers 12 months to 24 months, young children 2 years to 12 years, adolescents 13 years to 16 years. It's pertinent to note that the risk in general anesthesia is inversely proportional to age, meaning that the lower the age of these patients, the higher the risk involved in administering anesthesia to them. For the sake of this conversation, for our discussion, we are going to lay more emphasis on the infant and the neonatal age group. Now, anatomy and basic physiology. We will start with the airway and the respiratory system. Now, as we know that neonates and infants have a larger head, a short neck, and a prominent occiput. The tongue is relatively large. The larynx is high and anterior at a level of C3 to C4, as opposed to the adult, which is about 6'6". The epiglottis is long, stiff, and flops posteriorly. The famous sniffing of morning air position may not necessarily help back mass ventilation or to visualize the glottis. The head should be kept at neutral position for us to be able to do that very well. So now these anatomic features that I've just described make the neonates and young infants obligate nasal breathers until about the 5 months of age. The cricoid cartilage is the narrowest point of the airway in children less than 5. The diagram here tries to elaborate on the airway anatomy of the neonates and that of the adult. As you can see here, that the neonates have funnel-shaped trachea with the narrowing at the cricoid ring or cricoid cartilage, while the adults have more of a cylindrical anatomy. Trauma to the airway easily results in edema. It has been noted that 1 millimeter of edema can narrow a baby's airway by 60%. This is because they have a smaller tracheal diameter. Of course, it's in keeping with the Hagen-Poisson equation, which says that flow is directly proportional to the change in pressure and the radius raised to power 4. Meaning that a reduction in the radius, by a 2-fold reduction in the radius, will give about a 16-fold increase in resistance and reduction in flow. So the neonate and infants have limited respiratory reserve. Horizontal ribs prevent the bucket handle action that is seen in the adult and limits the tidal volume. So the ventilation is primarily diaphragmatic and rate dependent. So because of this, there could be diaphragmatic splinting from intra-abdominal tumors or raised intra-abdominal pressure from gas filling the stomach, which would inadvertently affect the adequate ventilation in these children. So at birth, each terminal bronchus open into a single alveolus instead of a fully developed alveolar cluster. Neonates and infants have fewer and smaller alveoli, reducing the lung compliance. Alveoli growth continues by multiplication until the 6 to the 8 years of life. Their cartilaginous ribs cage makes their chest wall very compliant, as opposed to the lung compliance, which is quite reduced. Intercostal and sternal recession is common with increased work of breathing or airway obstruction. There's a decrease in functional residual capacity, which limits oxygen reserves during period of apnea and can predispose to atelectasis and hypoxemia. Hypoxic hypercapnic ventilatory drives are not well developed in neonates and infants. Unlike in adults, hypoxia and hypercapnia may depress respiration in these patients rather than to stimulate it. The closing volume occurs within tidal breathing in the neonates. The application of CPAP improves oxygenation and reduces the work of breathing. The narrow airway results in an increased resistance up to the age of 8 years, as we previously said. The control of respiration in newborn infants, especially premature neonates, is poorly developed. There is an increase in the incidence of central apnea, which is actually cessation of breathing for up to or greater than 15 seconds. The likelihood of this apnea increases with patients who is given a drug with like has sedative effect. And apnea is a very common post-operative problem in preterm neonates. The incidence is reduced in by post-operative administration of xanthine derivatives like the theophylline and the caffeines and other respiratory stimulants. So thus admits for overnight oximetry and apnea monitoring for all children less than 60 weeks post-conceptual age who have had surgical procedures, no matter how minor. Neonates, infants, and young children relatively greater alveoli ventilation and decreased functional residual capacity compared with older children and adults. The greater minute ventilation to functional residual functional residual capacity ratio with relatively greater blood flow to vessel-rich organs lead to a rapid increase in alveolar anesthetic concentration and the speed of inhalational induction. This is due to high metabolic rate and alveolar minute ventilation. Volatile agents achieve a more rapid induction plus emergence than with adults. Of course, we know that the minute ventilation or the minute volume is opposed to the tidal volume times the respiratory rate. This table here tries to elaborate the different respiratory parameters comparing the neonate with the adult. Of what you have noted here is the respiratory rate, the compliance, and the oxygen consumption. The respiratory rate here will say that the neonates have about 30 to 40 cycles per minute as compared to the adults with 15 cycles per minute. Also the lung compliance is also very reduced in the neonates, about 5 mL per centimeter of water, as compared to the adults who has about 40. Oxygen consumption is also markedly elevated in the neonate. So for the cardiovascular system, we know that the cardiac output is rate dependent. So, and the heart behaves as a fixed cardiac output state. This is because in the neonate, the myocardium is less contractile, causing the ventricle to be less compliant and less able to generate tension during contraction. This limits the size of the stroke volume. We know that the cardiac output is equal to the heart rate times the stroke volume. Where stroke volume becomes fixed, the cardiac output can only be dependent on the heart rate. Hypoxia and acidosis may reverse closure of the foramen ovale and ductus arteriosus, leading to pulmonary hypertension and right to left shunt. This should be avoided. Cardiac output in neonates are up to 200 mL per kg per minute as compared to adults, which is about 70 mL per kg per minute. There is parasympathetic overdrive, which is vagally stimulated, and this is because the sympathetic nervous system and the baroreceptor reflexes are not fully mature. Activation of the parasympathetic nervous system, anesthetic overdose, or hypoxia can quickly trigger bradycardia and profound reduction in cardiac output. Bradycardia occurs in response to hypoxia and should be treated with oxygen plus or minus atropine. Neonates and infants with a heart rate less than 60 beats per minute require external cardiac compression. It should be treated as cardiac arrest. The immature heart is more sensitive to the depression by volatile anesthetic and to opioid-induced bradycardia. All neonates with midline defect should be assessed for related cardiac lesions. These are the Vactal anomalies. Hematology. On the average at birth, the total average blood volume is about 90 mL per kg, which drops in the infants and young children to about 80 mL per kg. The adult value 70 to 75 mL per kg is attained at the age of about 6 to 8 years of age. blood losses greater than 10 to 15% of blood volume should be replaced by blood, especially if you are anticipating more losses. The formula for maximum allowable blood loss is indicated as the volume of the red blood cells to be transfused in accordance with the desired hematocrit. So MABL, which is the maximum allowable blood loss, is equal to EBV times HO1 minus HO0 minus HO1 all over HO0, where the EBV is the estimated blood volume in mils, the HO, which is the original or starting hematocrit, and the H1 is the lowest acceptable target hematocrit. The target ratio for transfusion could vary in patients depending on the age and comorbidities. So at birth, 75 to 80 mils of the neonate hemoglobin is fetal hemoglobin. By the age of 6 months, the adult hematopoiesis is fully established. Fetal hemoglobin has a higher affinity for oxygen than the adult hemoglobin. So alkalosis produced by hyperventilation results in less oxygen being available, and it is therefore accessible to maintain pneumocapnia. This will prevent a shift to the left. So the table here also shows an age-related vital signs chart. Here, for guidance for the lowest blood pressure, lowest systolic blood pressure, the formula 2n plus 70, where n is the age in years, could be used. This also shows the characteristics of the neonates and infants that differentiate them from adults, grouped into physiologic and anatomic characteristics and differences. So the CNS, the blood-brain barrier is more permeable in neonates. Barbiturates, opioids, antibiotics, and bilirubin all cross more rapidly. The brain contains a higher proportion of fat, which may allow volatile agents to reach higher concentrations more rapidly. So the MAC peaks at about a year, then declines to reach the adult levels by the onset of puberty. All neonates feel pain, including preterm, which this is very pertinent to note. For the renal system, the renal blood flow and the glomerular filtration are low in the first 2 years of life due to high renal vascular resistance. Tubular function is immature until about 8 months, so infants are unable to excrete large sodium load. Dehydration is poorly tolerated. Premature infants have increased insensible losses as they have a larger surface area relative to the weight, mainly due to poorly keratinized skin. Dehydration ensues very rapidly in infants who are kept fasting for long, so resuscitation should be commenced. We should use a micro drip set or solo set for this, and the urine outputs, expected urine output of 1 to 2 mils per kg per hour should be estimated. For the hepatic function, liver function is initially immature with decreased function of hepatic enzymes. Barbiturate, opioids, for example, have a longer duration of action due to slower metabolism. Bilirubin metabolism is affected by poorly developed gluconeotransferase system. So rises in unconjugated bilirubin may lead to neonatal jaundice and kernicterus by crossing the blood-brain barrier. Some drugs, e.g. sulfonamides and vitamin K, can displace plasma proteins, can displace bilirubin from plasma proteins and exacerbate further jaundice. Carbohydrate reserves are low in neonates because of reduced glycogen stores. So, and the premature baby and the stressed neonates are especially vulnerable to hypoglycemia. In general, neonates at greatest risk for hypoglycemia are premature neonates, small for gestational age, or neonates on parenteral nutrition or born to diabetic mothers. Neonates also have a relatively increased incidence of gastroesophageal reflux. And we also know that vitamin K dependent factors are also low at term. So the routine administration of vitamin K, 1 milligram IM, may prevent hemorrhagic disease of the newborn and is recommended before surgery on the first week of life. So metabolism and temperature control. We know that the skin is thin. Low fat content and a greater surface area relative to weight promotes greater heat loss to the environment in this age group. Compounded by inadequately warmed operating room, prolonged wound exposure, administration of room temperature IV fluid and irrigation fluid, and the dry anesthetic gas. Neonates lose heat during surgery mainly by radiation, but also by convection, evaporation, and conduction. Also, the general anesthesia depresses the thermoregulatory response. Heat is lost from core to the cooler peripheral tissues. Even milder degree of hypothermia can cause perioperative problems, which may include delayed awakening from anesthesia, cardiac irritability, respiratory depression. It can potentiate or prolong the action of most anesthetic drugs, particularly the neuromuscular blockers and opioids. They also impair platelet function. So surgery should be done in a thermoneutral environment. So what's a thermoneutral environment? This is an environment in which the oxygen demand, heat loss, and energy expenditure are minimal. The temperature of such environment is 34 degrees centigrade for the premature neonate, 32 for the neonate at 10, and 28 for 28 degrees Celsius for the adult. Heat may be produced by one of the three processes: voluntary muscle activity, involuntary muscle activity, and non-shivering thermogenesis. Infants under the age of 3 months do not shiver. The only available method to increase their temperature in the perioperative period is through non-shivering thermogenesis mediated by brown fat. So what are brown fats? Brown fat is made up of multinucleated cells with numerous mitochondria and has an abundant blood and nerve supply. They are mostly found located mainly between the scapula and in the alveoli, also found around blood vessels in the neck and in the mediastinal area. The metabolism is mediated by catecholamines. The substrate used for heat production here is mainly fatty acids. The diagram here tries to illustrate the different places where brown fat is richly endowed in the neonatal or infant body. So, however, metabolism of brown fat is severely limited in premature infants and in sick neonates who are deficient in fat stores. A neonate has a body surface area to weight ratio of about 2.5 times that of adult. Thus, a neonate may become hypothermic very rapidly. In neonates, if neonates are allowed to become hypothermic during anesthesia, they attempt to correct this by shivering thermogenesis. This increases the metabolic rate and also might double the oxygen consumption. The protective airway reflexes of a hypothermic neonate are obtunded, thereby increasing the risk of regurgitation and aspiration of gastric content. The combination of hypothermia and prolonged action of neuromuscular blockage increases the chances of neonates hypoventilating after surgery. Now, so what are the measures that are put together in the theater to conserve heat loss? First, the child must be transported to the theater wrapped up in the incubator set at the thermoneutral temperature. The temperature should be warmed up to the thermoneutral temperature, ideally a few hours before the planned start of surgery. This interval will allow for the theater walls to be warmed, and this reduces the net heat loss by radiation. So all body parts not in use should be covered until the patient is fully draped. The child has to be exposed. If the child has to be exposed, overhead radiant warmers may be used. The child should lie on the thermostatically controlled heated blanket. Forced warming device system are effective in maintaining child's temperature as well. Also, the doors of the theater should be locked to avoid drought. Then cleaning fluid, blood, IV fluid, and other fluids for lavage should be warmed. The picture here shows a child under a bear hugger, actually a forced air warming blanket, which most probably called a bear hugger. Also using a bonnet, as you see in the baby here, or gamgee or polythene to reduce the heat loss from the head. Anesthetic gases humidified and warm to preserve ciliary function and to decrease heat loss from the respiratory tract. Temperature measurement is essential in neonatal age group, especially for those who have long surgeries and who are also expected to measure fluid and blood loss. So for the fluid balance, we know that 80% of neonatal total body weight is water. The value is higher in the preterm infants and reaches an adult level about 60% by 2 years of age. So the plasma volume tends to stay constant at 5% of total body weight, independent of the age. This chart here shows the 1 to 5 neonatal fluid requirements in mils per kg. Here, for the one, the neonates should get about 60 mils per kg per day, while up to the 5th day of life, about 150 mils per kg per day. So for the pediatric food requirement, we use the 4-2-1 regimen, where 4 meals per kg per hour for the first 10 kg, 2 meals per kg per hour for the second 10 kg, and 1 meal per kg per hour for subsequent kgs. Maintenance requirement makes no allowance for extra losses from gastrointestinalitis and intestinal obstruction and other inaccessible water loss from pyrexia. So, and also additional sodium and potassium may also be added to the requirements as needed. Perioperative fluid comprise the basic maintenance requirement plus replacement of other observed fluids, which we also stated. So the fluid here are isotonic crystalloids, example, the Ringer's lactate and the normal saline, or also blood could also be used according to the clinical needs of the patient. In addition, 50% glucose to 500 ml of Ringer's solution may be required in some infants perioperatively. Regular blood glucose measurement is essential in neonatal surgeries. So to make the 500 mils of dextrose in Ringer's, we get the 50 mils of 50% dextrose and add it to 450 mils of the Ringer's to get 5% dextrose in Ringer's. Blood sugars usually rise due to stress response of surgery. However, the following children may be at risk of hypoglycemia during surgery. Those are neonates who are less than 48 hours old, or if receiving a glucose infusion preoperatively. Any child with poor nutritional status, prolonged daytime fasting in children less than 2 years of age, prolonged surgery, especially with a regional block, which attenuates the stress response to surgery. So ideally, the blood sugar should be monitored in all children, and 1 to 2 mils per kg of 10% dextrose given if the blood sugar is less than 10 millimoles per liter. Never give 50% dextrose directly to the child. If it is not possible to measure the blood sugar, give 5% dextrose in the Ringer's for children at risk of hypoglycemia as a separate maintenance. Do not use this for bolus replacement or fluids to prevent the child from having hyperglycemia intraoperatively. So transfusion is required after 10 to 15 mils, 15% of blood loss. Blood volume should be calculated prior to surgery. Swabs should be carefully weighed and suction volume recorded. The 4% dextrose in 1/5 saline is no longer recommended because of the risk of hyponatremia in this age group. Now, the basic pharmacology. The pharmacological difference, some of the factors to consider when dosing anesthesia drugs are the weight, the disproportionately larger pediatric intravascular and extracellular fluid compartments, the immaturity of the hepatic transformation, biotransformation pathway, increased organ blood flow, and decreased blood protein for drug binding. Also, the child has a higher metabolic rate. The volume of distribution for IV drugs is disproportionately greater in neonates, infants, and young children, higher doses than in older children and in adults. The neonates also have decreased protein binding for some drugs. Most notably is the thiopentone, the bupivacaine, and many antibiotics. In the case of thiopentone, increased free drug enhances potency and reduces the induction dose in the neonates compared with older children. An increase in the free bupivacaine might increase the risk of systemic toxicity, and use should be done with care. Children must be weighed. All drug doses relate to body weight. But for convenience, In early childhood, a patient's weight can be approximated based on the age using the following formulas. So for the inhalational agents, neonate infants and young children have relatively greater alveolar ventilation and reduced functional residual capacity compared with the older children and adults. With greater minute ventilation to functional residual capacity ratio, with relatively greater blood flow to vessel-rich organ, which leads to a rapid increase in alveolar anesthetic concentration and speed of inhalational induction. Furthermore, the blood gas coefficients of volatile anesthetics are reduced in neonates as compared with adults, resulting in even faster induction time and potentially increasing the risk of accidental overdose. The table here shows the minimal alveolar concentration mark requirements for different age group classifications. So as see here, as marked with red, that of the infant is way higher than the others. Halothane and sevoflurane are less likely than other volatile agents to irritate the airway or cause breath holding or laryngospasm during induction. But in general, volatile anesthetic appear to depress ventilation more in infants than in older children. Sevoflurane appears to have the least respiratory depression. Sevoflurane is also favored as the induction agent of choice for inhalational induction in pediatric age group. For intravenous agents, after weight adjustment of dosing, infants and young children require larger doses of propofol because of a larger volume of distribution compared with the adults. Children also have a shorter elimination half-life and a higher plasma clearance for propofol. The same reason, children may require increased weight adjusted rates for infusion of propofol up to about 250 micrograms per kg per minute. Propofol is not recommended for prolonged sedation in critically ill pediatric patients in the ICU due to its association with greater mortality than other agents. Of course, the propofol infusion syndrome has been reported for very often time in the critically ill children. The features are essentially rhabdomyolysis, metabolic acidosis, hemodynamic instability, hepatomegaly, multiple organ dysfunction, which could ultimately lead to death. In contrast, neonates are more sensitive to barbiturates. They have less protein binding, a longer half-life, and impaired clearance. To help in tone induction of neonates is about 3 to 4 milligrams per kg, compared to the adult dose, which is about 5 to 6 milligrams per kg for infants. Opioids are more potent in neonates than in older children and in adults, so the use should be done with care. Morphine should be used with caution in neonates because of the hepatic conjugation is reduced, and you don't want them to start accumulating morphine 6-glucuronate in the system. Midazolam has the fastest clearance of all the benzodiazepines. However, midazolam clearance is significantly reduced in neonates compared with the older children. So the combination of midazolam and fentanyl causes hypotension in all patients. Muscle relaxants, all muscle relaxants generally have a faster onset, up to 50% less delay in pediatric patients because of the shorter circulation time than in adults. But infants will require significantly larger doses of suzametonium than the older children and adults. This is because of relatively large volume of distribution. So with notable exclusion of suzametonium and possible cisatracurium, infants require significantly smaller muscle relaxant doses than older children. The relative immaturity of the neonatal hepatic function will lead to an increased duration of action of drugs with primarily hepatic metabolism, e.g. the pancuronium, vecuronium, and rocuronium. But the atracurium and the cisatracurium are not dependent on hepatic barrier transformation, so there's no prolongation seen in these drugs. Children are more susceptible than adults to cardiac arrhythmias, hyperkalemia, and rhabdomyolysis. So when a child experiences cardiac arrest following the administration of suzametonium, start immediate treatment for hyperkalemia. A prolonged resuscitative efforts may be required. For this reason, suzametonium is avoided for routine paralysis for intubation in children and in adolescents. So generally accepted indications for IV suzametonium in children include a rapid sequence induction with a full stomach and laryngospasm that has refused to respond to positive pressure ventilation. So unlike adults, the children may have profound bradycardia and sinus node arrest following the first dose of susamethonium without atropine pretreatment. Rocuronium is considered to be the drug of choice when a relaxant should be used during a routine intubation in the pediatric patient with IV access. This is because of this fast onset of action when compared to other non-depolarizing neuromuscular blockers. So the lower doses may be needed for faster onset of action, 0 to 9 to 1.2 milligram per kg. But the downside is that the duration of action is now prolonged, even up to 90 minutes. Atracurium or cisatracurium may be preferred in young infants, particularly for short procedures, because this drug consistently displays a short intermittent duration. Now, for the anesthetic considerations proper, we know that we are, in contrast to the adults who are usually most concerned about possibility of death, children are principally worried about pain and separation from their parents. So the preoperative visit is essential in order to establish rapport and to allay anxiety. So communication should be simple, informative, and truthful. Avoid wearing a white coat, involve the parents, try to question the child directly when appropriate, and stay at the eye level if possible. For all elective surgery, it should be possible to prepare the child and family for what is to be expected in the perioperative period. All children should be visited perioperatively by the anesthetist responsible for caring for them in the perioperative period. Children who are systemically unwell should not have elective surgery. Example, children who are down with malaria. Also, children who have active viral illness such as chickenpox should not have elective surgery. Also, children who have recently been immunized should not have elective surgery because of the risks of infecting other immunocompromised patients. And a child should be weighed before arrival in the theater because weight is the simplest and most reliable guide to drug dosage. Veins suitable for insertion of cannula should be identified, and if possible, local anesthetic cream applied and covered with an occlusive dressing to prevent the child from leaking it. So the topical agents that can be used, we have the EMLA cream, which is a recipe mixture of 2.5% lignocaine plus 2.5% prelocaine at 1:1 ratio, applied for at least, when applied for at least 45 minutes would numb the area. Other ones, the amitrop and the ethyl chlorides could also be used. For the history, a quick past medical history, surgical history should be taken. Blood transfusion history, immunization history, last oral intake, allergies, and present medications with history of any cardiac disease also should be noted. Upper respiratory tract infection in the presence, anesthesia in the presence of upper respiratory tract infection is associated with a higher risk of complication in young children. So there is also increased incidence of excessive secretions, airway obstruction, laryngospasm, and bronchoconstriction. This will lead to hyperreactive and hyperactive airway. So the risk is 5-fold when using an LMA, and also increases to about 10-fold if a child is to be intubated. Children with moderate to severe chest infections should be postponed. Surgery for them should be postponed. This will include those with productive cough, purulent chest or nasal secretion, pyrexia, and signs of viremia and constitutional illness, including diarrhea, diseases, and vomiting. A child with a mild upper respiratory tract infection is a bit of a dilemma. The history is crucial and should be done by a senior anesthetist. This is so I will be able to differentiate between an infectious cause of rhinorrhea and infectious cause of rhinorrhea and an allergic cause. A child assessed to be post-viral apyrexial with no chest signs and constitutionally well is probably fit for surgery, even if they have a runny nose. But this decision should be made by senior anesthetists. In such cases, one should consider giving anticholinergic pre-medications, avoiding intubation if feasible, and humidifying the inspired gases. Also, these patients should be observed for longer periods in the recovery room. Significant upper respiratory tract infection requires postponement for 2 weeks, but this should be 4 weeks if it's a lower respiratory tract infection. About consent, in Nigeria here, the age of consent is about 18 years, and signed consent is usually the preferred option. So for a child with murmur, usually these children would have been under the care of the pediatric cardiologist, but if not, if there's any doubt, surgery should be deferred until a formal assessment has been made, and also the review should be done by a senior anesthetist. For physical examination and the investigation, physical examination is general and systemic review with special focus on the cardiovascular system, respiratory system, the airway, and the weight of the child. Investigation will have routine and specific investigations required for the child. Pre-op fasting instructions are designed to minimize the risk of regurgitation of gastric content and subsequently pulmonary aspiration. Prolonged fasting does not further reduce the risk of aspiration and can lead to dehydration and hypoglycemia in children and should be avoided. Infant may be at greater risk of regurgitation due to reduced lower esophageal sphincter tone and a tendency to distend the stomach during mass ventilation. Clear fluids is recommended to be given safely up to 2 hours pre-operatively. This will help to reduce irritability at induction. For the fasting guideline, we have clear fluids for 2 hours, breast milk, we have 4 hours, formula milk, 6 hours, solid food, also 6 hours, and then the fatty foods with meats, 8 hours of fasting is recommended. But it's also pertinent to know that these recommendations is for healthy neonates and infants without risk for decreased gastric emptying or aspiration. So for the pre-medication, some children would require pre-operative sedation. This example are those with delayed developmental milestones. To warn the parents that child's head may become floppy and would need support. So sedative pre-medication, especially in the preschool age, may decrease parenteral anxiety, improve patient compliance, and decrease the incidence of post-operative behavioral changes. One of the drugs that's used is oral midazolam, which is the most commonly used, and acts with a dosage of 0.5 milligram per kg. Acts within 15 to 30 minutes after administration. And also the IV midazolam formulation can be used, but because it's bitter, it's advised that you mix it up with juice or with paracetamol syrup. Ketamine can be given orally, 2 to 5 milligram per kg as a sole drug or in combination with midazolam, the midazolam ketamine glycopyrrolate combination. For induction should occur in a child-friendly environment where possible. We should have to pre-calculate the dose of atropine and suzametonime in the prepared syringes, emergency drugs drawn and labeled for bradycardia and laryngospasm. So attached to monitors, pulse oximeters, ECG, BP cuff, and others. Inhalational induction, sevoflurane is a volatile agent of choice, as we've earlier said. The suspected for suspected difficult airway, use sevoflurane. If halothane, if not available, halothane can also be used. But after induction, you can now maintain your anesthesia with other volatile agents. So the induction agent of choice is usually propofol, 3 to 4 milligram per kg, with a 1% lignocaine, 1 ml per 10 mils of propofol added to reduce the pain on injection. Thiopental is also a suitable alternative and is licensed for neonates, 2 milligram per kg. Ketamine, 2 milligram per kg is reserved for hemodynamically compromised patients or those who with severe cardiovascular disease, or usually in conjunction with fentanyl, 1 to 2 microgram per kg. So the emergence phenomenon from ketamine are less common in children, but increased incidence of PROV and also higher salivation. So apparatus such as connectors and the humidification devices significantly increase dead space and should be kept to the minimum, especially when the child is breathing spontaneously. The Jackson-Lee modification of area TPs is the breathing system used traditionally for children less than 20 kg. Above that, the circle system of the veins can be used. So reservoir bag also allows the application of CPAP. This may be helpful in improving oxygenation. Here we have the Gardel Airway, which is a useful adjunct for airway optimization. The reliable way to know the size is actually to place the flange of the airway at the angle of the mouth. Correctly sized airway should reach the angle of the mandible as seen in the picture beside. For estimation of the tracheal tube, we use the following formula N over 4 plus 4, where N is the age in years. It's also important to keep a tube 0.5 millimeters larger and 0.5 millimeters smaller while trying to intubate the child. For oral intubation, length is about age over 2 plus 12 centimeters. We'll give you a rough guide. And for nasal intubation, age over 2 plus 15 centimeters. So the most important technique in the management of the airway is judicious use of CPAP. Now, ensure a good seal with the face mask and then partially occlude the bag of the area's TPs. Blood sugar should also be checked regularly. Even a small air bubble in the IV fluid can be potentially harmful to infants, especially in the presence of an ASD or a VSD. So for monitoring, there is no substitute for an experienced, vigilant anesthetist directly observing the patient. You use the standard monitoring plus extra, that's the pulse oximeter, ECG, BP, appropriate BP cuff, and capnography. Temperature monitoring is important, and the neonate, and also the use of routine precordial. The advantage for the precordial is that it permits a continuous qualitative assessment of heart sounds and ventilation. But more importantly is that it ties the anesthesis to the patient's side. So for emergence and recovery, residual neuromuscular blockage should be antagonized using neostigmine plus garaparate or atropine. So extubating deep or awake, not in between. Most children should be extubated awake if they are warm and with adequate analgesia. This can be tolerated, except for children who are post-tonsillectomy and other procedures that coughing is to be avoided. Neonates should be extubated awake, preceded by an assisted ventilation to pre-oxygenate the lungs. Pediatric patients are particularly vulnerable to two post-anesthetic complications, laryngospasm and post-intubation croup. For laryngospasm is more immediate compared to the post-intubation croup. For the treatment of laryngospasm, a gentle positive pressure ventilation with the forward jaw thrust. You can give IV propofol at 1 to 1.5 milligram per kg, or paralysis with IV suzametonine at 0.5 to 1 milligram per kg, or using urocoronine with controlled ventilation. So for the post-op pain should be adequately treated intra and post-op. Commonly used parenteral opioids include the fentanyl, morphine at 0.05 to 0.1 milligram per kg, also the hydromorphine and the pethidine. A multimodal technique also incorporating the NSAID, acetaminophen, opioids, and regional block is also recommended. For suppository diclofenac, we have 1 to 2 milligram per kg, or the ketorolac at 0.5 to 0.7 milligram per kg. Do not use opioids in children less than 6 months of age. This is due to the poorly developed renal system. So patient-controlled analgesia can also be used instituted in older children, and regional block are very effective. Example are the caudal block and the epidural. The table here shows like a regional anesthesia in pediatrics, where it's related to neuraxial block and the peripheral nerve block. And of course, the use of ultrasound has been in the increase and is wholly recommended for these procedures. Now, post-operative nausea and vomiting. POMV is uncommon under the age of two years. Predictors of risk include high-risk procedures, adenotonsillectomy or spleen surgeries, or people who already have travel sickness and previous POMV. Also, opioid increases the risk of POMV by about 30%. Regional anesthesia and other opioid sparing techniques are encouraged. The combination of antiemetic ondansetron 0.1 milligram per kg and dexamethasone 0.1 milligram per kg is more efficacious and preferred, better than the monotherapy. So for day case surgeries, we know that only experienced surgeons and anesthetists should undertake day case surgery. Children who are under the 60 weeks post-conceptual age are exempted from day case surgeries. Children who also have diseases that are not well controlled, e.g. poorly controlled epilepsy and other metabolic diseases like insulin-dependent diabetes mellitus, should not undergo day case surgery. This group of children should be admitted electively for overnight stay. So in conclusion, anesthesia for pediatric patients is unique and requires special consideration, even more so in neonates and infants. A good understanding of the peculiarities, anatomy, physiology, and the basic pharmacological differences is key to favorable outcome. Adequate preparation and a skilled anesthetist is required. The pediatric anesthesia should not be attempted by a novice. Always get someone with experience to be with you in the theater. These are my references. Thank you for listening.